Thank you very much. It is indeed a pleasure to be here. And the theme of what I'm going to try to discuss today will try to show the similarities between what we do in clinical trials and clinical practice. And I'm going to trace back a little bit of the history on how the trials that we've done have evolved and how some of the same principles are now becoming routine in how we manage our patients. So to start off with my disclosures, I've had the privilege of working with a number of pharmaceutical sponsors, and as mentioned by my predecessor, again, this has enabled us to develop some very, very effective drugs, particularly two that were non-toxic that I was working on, namely abiraterone plus prednisone, as well as enzalutamide. So just to start out with a disease framework, we've come up with a schema we call clinical states, which we think of in terms of milestones in the illness. And this is the framework on which we base our clinical practice approaches as well as our clinical trial approaches, specifically designing trials depending on the particular needs of a specific patient group. And as you heard earlier, the landscape has changed dramatically in the past 3 years. And you can see where we have positioned the various agents, as mentioned earlier, alpha-radin, again, being appropriate for patients who have symptoms, independent of whether or not they've had docetaxel. The hormonal agents, first approved in the post-hormonal space, as a reflection of our understanding of the biology of the disease. And this was not simply a matter of because I or someone decides to get docetaxel, that tumor can still remain hormonally driven. So the question then is, how do we move forward? And just to highlight some of the trials where the simple addition of an agent to docetaxel was not successful. Not only was it not successful in terms of improving outcomes, but in fact there were two situations where in fact the experimental group did worse. So there's nothing more disheartening as an investigator when the trial you've been running shows that your experimental arm actually does inferior to the standard of care, which really emphasizes why it's important to ask the questions and not assume that the data will necessarily be positive. So I'd like to cover the guiding principles that we use in everyday practice, which actually evolved on our difficulties in understanding how different drugs affected prostate cancer. I started in this field, I'll say a decade before Dr. Sartor. And again, at that point, we did not have PSA. We basically had radiographs. We had bone scans, which are really subjective, and CT scans were also relatively new. So the disease we were treating at that time wasn't quite different. And as we were trying to standardize outcomes and standardize trial metrics in prostate cancer, an international group of us got together, locked ourselves in a room on multiple occasions to try to come up with recommendations in terms of how we design trials and approach patients. And it really can translate the approach to very similar to what you do in practice. And we're all focused now on various biomarkers, but the reality is when the patient walks into the room, you are in fact looking at that patient as a biomarker. How does the patient, do they look fragile? Are they old? Are they humbled over? Are they walking in clearly very fit? And your approach to each of those patients will be different. So in your own mind, you have made a biomarker type decision. So we can call that performance status, but in essence, it's the same as a gene, as our approach to a gene. If we see a particular gene and we know the drug hits the target, we'll say, okay, this is the appropriate drug. There absolutely is no difference. So again, if you think about it from your first encounter, you are thinking about how do I approach this patient to do the most benefit with the least harm. So when we set up our clinical states model, we really said we don't really care if a lymph node in the pelvis that's 2 centimeters in size drops by 50%. We're really more focused on necessarily making that patient feel better or making the pain improve. So when we think of a trial, we think of what we think in practice. What our treatment intent, which is to benefit a patient, must potentially provide a clinically relevant and tangible benefit, which is the same way the FDA thinks about it. What is the benefit relative to the potential risk? So we look at the patient and we say, what's the manifestations of the disease now? If the patient is hurting, that's the first priority. He's not worried so much about survival acutely. He wants that pain to go away. Then you can think about it. So again, if the manifestations are significant, or he has metastatic disease, for example, in liver, you're going to treat that patient relatively acutely and potentially a little bit more aggressive. If there's no manifestations, if the patient's really fit, you'll think, okay, what's the risk that something might happen? And again, in earlier disease states, if we see a patient and nothing is predicted to happen in 3 or 4 years, there's no urgency to treat that individual. In contrast, if the patient has had previous radiation for pain and the pain's gone and he has multiple bone metastasis, the likelihood is that patient's going to become symptomatic. So you would offer a treatment to prevent that significant event from happening. So again, if the risk probability is high, we'll intervene. If not, we may defer. So again, we think of our objectives in terms of unmet needs, which ultimately become the indications for drugs. So instead of worrying about tumor shrinkage, we say if the manifestations are significant, we want to eliminate them, relieve them, or control the disease if they're present, or prevent or delay new ones from occurring. Survival is simply delaying death from disease. I'm really challenged with this. Okay. And for the unmet needs for the asymptomatic patient, what's his prognosis? If you treat the patient, is it working? And ideally, we'd like to be to the point where we are able to say this drug for this patient, but we do have some clues now based on the clinical manifestations of the disease. I won't dwell on this, but if you think about the approved indication, this actually fits the mantra quite well. Because, again, you're controlling, relieving, eliminating symptoms, controlling pain, radiopharmaceuticals, mitoxantrone, prednisone, the first systemic chemotherapy shown to palliate pain, alpha-radin, symptoms from bone metastasis with no significant other organ involvement. We do not have any approvals based on PSA, and we're working to develop a potential surrogate biomarker in the use of circulating tumor cells. Again, skeletal-related events, significant skeletal events, again, prolongation of life. These match the mantra or the way we have outlined our working group criteria. So what's the focus now? Are there subsets of patients that you see in your clinic after you evaluate this extent of disease which can guide you on how to manage the patient in terms of a therapy which might be indicated or not? So in point of fact, if you see enough prostate cancer, you realize there are distinct subtypes. There's a small proportion of patients who relapse locally and never metastasize. That can be a very difficult management group. There's the biochemical recurrence, the non-metastatic rising PSA castration-resistant state. No approvals in this space, very difficult to do trials, but in fact this has now become a phase 3 space. There's a proportion of patients where the disease only goes to lymph nodes and never goes to bone. There's the most common manifestations, bone with some nodal disease, and you can see the check marks indicate where there is in fact an approval. For visceral disease, Provenge is clearly contraindicated, similarly for alpha-radin, because the likelihood of this contributing, again, the drug simply will not work. You can have some nodal disease if a patient is symptomatic with alpha-radin. And again, symptoms of pain, although patients in most of these trials had pain, the formal indications within the labels are checked here. Okay, how do we sequence the available agents? Should they be used alone in combination? Intuitively, we'd like to combine them. We learned from docetaxel that may not in fact work. And just to think about how we would approach prostate cancer in the past, the typical patient who is progressing with non-metastatic castration-resistant disease or metastatic castration-resistant disease would typically see 1 or 2 hormonal therapies before proceeding to docetaxel, and I agree completely with Dr. Sartor. This was an artificial bar, and again, when it is actually utilized varies quite differently. This bar of something a patient is not anxious to start is not going to change. But with the availability of more agents, it's likely to happen later, and the patient group that you're going to be treated is going to be very, very different. So now, with effective agents in this space, Sipluleucel-T, alpha-radin, abiraterone plus prednisone, and hopefully enzalutamide shortly, what you're going to see is more of these agents because they are efficacious and prolong life, and docetaxel is likely, or cytotoxics, will likely be utilized even later. Again, you've seen the survival curves. Just a reminder that it was found in metastatic prostate cancer samples that the level of androgens were actually higher than in patients who did not have their testicles removed. This was related to overexpression of the androgen biosynthetic machinery. Abiraterone is a targeted agent for CYP17, which is one of the enzymes in the pathway. And again, this is no different than a tyrosine kinase. See the target, hit the target, the drug works, no surprise. Do we know exactly which patient has overexpressed enzymes? We do not. But again, we do know that there is a relationship between measured androgen levels and ultimately survival. Medivation 3100, again developed by Dr. Sawyers, now known as enzalutamide, has greater avidity to the receptor, blocks the transport of this receptor to the nucleus, blocks the binding of the receptor complex to DNA. Again, this was overexpressed androgen receptor, shown by Charles to be an oncogenic change in signaling. See the target, hit the target, and you have prolongation of survival with a targeted, efficacious, safe drug. So this did, in fact, change the paradigm. We had been arguing for a long time that there were responses to secondary hormones. These tumors were not hormone refractory. And it's not so much a semantic argument, because if your mindset is that you're not going to utilize a hormonal agent, you're actually denying a patient an effective treatment. And it really established that by understanding biology and knowing the targets and developing drugs for those targets, you can improve outcomes significantly. Now, obviously, we're trying to understand what are the resistance mechanisms to these secondary agents, and there are some advances and trials that will ultimately address these questions. Okay, but it's important to remember that no different than what happens in the laboratory, if you treat patient with drug A, the tumor that emerges is going to be different than a tumor that has never seen drug A. So you saw one example, just to reiterate it. Here's a fairly complicated slide. I ultimately was able to discern it. But essentially, it's looking at the waterfall plots in patients who had been responded in red to abiraterone. Again, a group showing very dramatic declines in PSA, a group that did not respond at all, who then received enzalutamide. And you see there were some patients who were cross-resistant to both agents that did not cross-resistant, resistant to both agents. There were some who didn't respond to abiraterone who responded to enzalutamide, and then there's a whole group in the middle. So this is clearly not going to be a simple or straightforward exercise, and we can't necessarily assume when we look at aggregate plots that that's going to change the outcome for an individual in terms of trying the drug. The second example, as you saw from Dr. Sarda, the curves by Dr. Noonan, again, it looks quite different. This is the waterfall plot for abiraterone in the post-chemo space. And again, now looking at patients who receive abiraterone progressing on enzalutamide, slightly different subset than the previous, and you see, again, a very different outcome. So what's really important when we're designing our trials or when we're seeing patients in practice is to think very carefully about the specific treatments they have received and also the time interval at which they receive them. Because if someone is progressing directly, for example, in docetaxel, that's a very different patient than someone who has responded, has not seen the drug for a considerable period of time. And now with some of the more advanced molecular techniques, we'll be able to monitor some of these changes more closely at a molecular level. So again, this is a question for the audience. I would just ask you now, I know it's maybe a little bit out of turn, but given the choice and assuming that these drugs are equivalent, which one would you use first, abiraterone plus prednisone? We will assume that the enzalutamide trial shows similar efficacy to the abiraterone study. So this is, again, theoretical. Can we get a poll? Or, I don't get a poll, we'll do it later. Okay. So understand, what's that? No, that's fine, no problem. Understand now that what we're learning is that if you've been on prolonged, one of the mechanisms of resistance to enzalutamide is activation of the glucocorticoid receptor. So now the situation is getting even more complicated. So here's a trial that really simply has to be done. It's to essentially try essentially what you could call a horse race, 3-arm study, enzalutamide, abiraterone plus prednisone, single agents, combinations of single agent, at progression, crossover. Now the endpoint obviously has got to be time here, as opposed to necessarily look at these agents independently. Again, what will happen first is the Alliance Cooperative Group led by Dr. DeMorris will be doing this trial, but unfortunately it's only a 2-arm study. But without these types of studies, we're not going to have the information to understand who responds to one drug, and the real question of cross-resistance from a patient point of view, they're looking at the totality of time that their disease is controlled, and whether this the combination will be superior or inferior at this time, we actually don't know. So are there particular endpoints that you can adopt into practice where that might better guide management? So one of the things we were very careful about in the working group was says, again, the rise in PSA that occurs in a patient who's responding can be quite variable. In some cases, they skyrocket up, and those are unequivocal. But what about the case where it's drifting? Is this a situation where you should necessarily stop treatment? And you can write your response criteria that says it's 25% up is bad, 50% up is bad. The reality is we simply use that to mark time consistently, but it doesn't necessarily mean that the patient is no longer benefiting and you should stop the drug. So here's an example of a patient who came to me on abiraterone. He started here, rising PSA. These are the intervals at which we're assessing scans. He was on protocol, so he's being measured. And he has 1 PSA about 8 weeks into treatment, which is clearly higher. And he had some bone pain at the time, and we said, okay, you're having some symptoms. Let's just make sure that your disease is progressing. We'll check some scans. Comes back about a month later, his PSA's dropped a little bit, pain went away, his scans are stable. So we said, all right, let's just sit tight, in part because there was no additional treatment after this at the time. So it turns out most of his pain was related to his to over-exercise. He was playing golf, and we just sat tight, and he went on in stable disease for approximately 2 years. So maybe I held on a little bit too long here. But again, I could have stopped him here at about 3 months, and he would not have had an additional 21 months of clinical benefit. So again, be very careful in terms of how you interpret scans. Here's an example of the drifter. Dramatic drop in PSA, everybody's happy. Now it's going up a little bit, and you're saying, okay, when do I stop? He's starting to get a little nervous here. Meanwhile, we're scanning him. This interval is 3.5 years. Now, he shows no symptomatic or radiographic progression. Ultimately, he did need some radiation. So yeah, maybe we went a little bit too long. But again, we could have, depending on how we define our protocol, we may have had to stop him here and deny him 2 years of his safe treatment. So again, what we've learned is that PSA alone does not explain a lot of survival, and it has to be interpreted very carefully. And again, depending on what treatments you have, if you just potentially have a few clones of cells, or if you do a PET scan, you may find that there's one dominant lesion that's causing the problem. And we've built into our protocols now to be able to radiate that lesion and not necessarily have to stop the whole treatment. So again, a second metric that came related to the issue of pseudoprogression was the bone scan findings. Now again, depending how you look at bone, this is a conventional bone scan. This is a glucose FDG PET scan. Here's a androgen scan, or just looking at where androgen is expressed in the tumor. The good news is this is the same patient. So depending on which scan method you use, you see a very different situation. So one of the things we built into our guidelines, we says, okay, you may see 2 lesions at your first follow-up scan, but in some cases that's actually healing or pseudoprogression. And this was a very important component of the Cougar 302 pre-chemotherapy trial, because in point of fact, when they looked at the first follow-up scan, there were 229 patients where the first scan looked worse. 72% were not confirmed on a subsequent scan. So 72% of the patients who were actually of the patients who showed a worsening scan did not have disease that was worsening. So again, when you're using scans in a prostate cancer patient, interpret them very carefully. Circulating tumor cells again has been explored in a number of different tumors. Many of the studies have been relatively small, but it has consistent results in virtually every tumor type in which it has been analyzed, that if a patient has high cell counts at the beginning, as opposed to someone who does not, their prognosis is worse. And we've been exploring this in different trials, but I thought you would be interested to see that when we included this in the phase 2 trials of abiraterone acetate, these are the trials run by Johan de Bono's group, and again, ours at Sloan Kettering, the proportion of patients who had unfavorable counts was very similar. Now, these were protocol-defined eligibility, so you can see the test was fairly robust in terms of the proportion who showed elevated counts, and those that dropped were very consistent. And important to remember, this degree of drop was ultimately associated with survival benefit, and we're able to present the other day that, in fact, using a combined biomarker of CTCs and LDH, we actually were able to show that the Prentice criteria for surrogacy were satisfied in this trial. So we will typically get an initial cell count, and if it's elevated, that becomes another aid to monitoring. So will using newer agents early improve outcomes further? This has been the paradigm in breast cancer, where you take effective treatment in metastatic advanced disease and move it early, and you start to see cures. So again, I'll just give you one example of a trial we've started. There are certainly others, and we by no means have a monopoly on this. But the question is, if you think of the typical hormonal ablation, which will take androgen levels and androgen signaling in the tumor down to a certain level, and now with agents such as abiraterone plus prednisone, where you can drive androgen levels down to the 1 nanogram per level, can we, in fact, are there tumor cells in a patient when they first present, which are all androgen sensitive, and can we potentially affect cure? That's a big word. It's going to take a long time in multiple trials. I'm getting older. I don't want to wait for the survival endpoint. So we're trying to use as a screening tool, can you eliminate PSA and in an intermittent type hormonal therapy approach so that when androgens are increased and the patient recovers, that the PSA stays down for a long period of time. So this will potentially allow us to ask that question. Affirm started here. Why did it start here? It was biologically appropriate because the tumor, again, was driven by overexpressed enzymes, and you saw the PREVAIL results, and now it's moving earlier. There's data from Dana-Farber and the University of Washington that, in fact, you see greater responses in the primary when you combine them. So PSA is a target gene. We knew there were many reasons why we would use these agents in castration-resistant disease. It's a clinically relevant target. But the trial that we've designed is looking at patients with a rising PSA and no prostate, a rapid doubling time. These are patients at risk of metastasis and death from their tumors. We had a standard GnRH antagonist, abiraterone prednisone versus dagerelix versus abiraterone plus prednisone. The endpoint will be undetectable PSA when the testosterone is recovered. The key to all of this, as Dr. Sarda mentioned, is we have to generate the evidence. We cannot make assumptions. These are going to require very carefully designed trials. They are different than we conducted in the past. We can see emergence of resistance, which we haven't seen before, again, while the patient is seemingly responding radiographically. So again, it's going to be a very exciting time. The last 3 years have been extremely exciting and rewarding, and we're looking forward to future progress. Thank you for your attention.